All right, so just as a reminder, this is a discussion, not a seminar. So it's very interactive. Jump in at any time with questions and comments. The more discussion, the better. You can turn your audio on and off, your video as well. So if you want to keep it off, you're welcome to. If it gets loud, we might mute you from our side in case you forget. Just as a friendly reminder, this is being recorded for possible future use of MOPA, and the views and opinions expressed during this presentation are our own and do not necessarily represent the views of any of the Missouri Psychological Association. This is for category B CE credits. So if you have any questions about that, please contact Emily at support@mopaonline.org and just make sure you're signed in with your full name so we can track your attendance. Thanks for being here. I'm going to pass this off to our panelists and let them introduce themselves and yeah, have a great round table. We'll start with Kristen.
Morning all. I'm Kristen Thompson. I'm a licensed clinical psychologist, and I'm also the system director for pediatric integration at Burrell. My background is in ped psych, and that is absolutely my first passion, and still get the privilege of supervising some ped specific locations. I will hand off to Holly.
Hi, my name is Holly Roberts. I am the Director of Integrated Care at Monroe Meyer Institute at University of Nebraska Medical Center, and help run some of our grants related to integrated care and also do clinical training related to integrated care. I'll pass it to Kristen Johnson.
Hi, I'm Kristen Johnson. I am a new integrated care psychologist working in Columbia at the University of Missouri. I'll be working at a pediatric office here.
Micah, you're up next.
Hi guys, I'm Micah Gillen. I'm a behavioral health consultant at Northside Pediatrics for Cox Health, and I work for Burrell. It's a mouthful, but as we know in the BHC world, things are busy and crazy. So I had a consult right before this, so I'm sorry I'm getting on late. So
Thanks, Micah. So pediatric integrated care, pediatric primary care specifically, I guess we did distill it down that much. It's still a massive topic. And so, when we met before this to talk about what we wanted to make sure we highlighted for you all today, we have a giant list. We're not going to get through it all, but we really wanted to, oh my goodness, Michaela, I forgot you. I'm sorry, I'm going to stop talking and hand off to you.
Oh, it's fine. And I see Robin joined too. I'll tell you what, our minds and our brains are twofold these days, and our schedules. So it's totally fine. Grace. I do want to say that I think we've reached our Kristen limit for the meeting though. So any other Kristens with an EN will have to see the line. Of course, I'm kidding. I'm Michaela Milbach, and I am the Deputy Chief Clinical Officer of Outpatient and Psychological Services, and I oversee at Compass Health. I oversee our BHCs as well, and integration is a major passion of mine as well. We've started an integration committee internally, and this is such a wonderful time to nerd out on integration every month. So I will hand it off to Robin, who looks like she just came from surgery.
Robin, you need to unmute still, can you? Where you are?
I can. I was saying surgery was successful. I learned that there's an ICD code for being crushed by an alligator. So that was surgery. I'm just kidding. I'm Dr. Robin Lute. Nice to see everyone. I am part of the MOPA committee for integrated healthcare, and I work as a behavioral health consultant in a system that Burrell is contracting with, Bothwell. We're increasing services here with interns, so and myself, but we're building a program basically, so happy to be here.
I will resume kicking us off. I don't think I've forgotten anybody else, but Anyway, we tried to narrow pediatric primary care down into a few areas we wanted to make sure we talked about, really mostly focusing on the things that make it different. So assuming some basic information about integrated primary care integration, what makes pediatrics specifically different, and what are some of the different challenges we navigate and how we do that. So we wanted to make sure we touch on a little bit about working with parents and families. We'll talk a little bit about what we dubbed the slippery slope of peds, because you get pulled into really being a traditional mental health provider, I think especially in peds. We want to hit on some issues around diversity and ethics, because those are unique in pediatrics, and just some information about the workflow and how that also is just different in pediatrics. Holly, do you mind if I hand it off to you? You had some good information, I think, to get us started with.
Sure, I'm happy to get us started, and thank you again for having me. This is my first time, so I really do want to help make this interactive. So please do jump in with questions and thoughts. But the first place that I'll start is, I guess, in the differences between children and adults when we're working in integrated care. One of many things that we talked about as we were planning for today was that, we often want to meet children before things get too far out of control, and that they are sometimes in a spot where they don't even need a diagnosis. But in order to see them, in some for some insurance companies and in some states, a diagnosis is required. So looking at, I guess, from that perspective, but really if we zoom out a little bit further, we're looking at, the reasons why we do this, and for pediatrics is to try to prevent something from getting to where we know it can, or where it can go. And so meeting these, addressing these things early. So we're really focusing on prevention strategies, just as much as we're focusing on managing a condition. So prevention, screening, making sure we're seeing the right children in the right place. And if not, making sure we're triaging them to the right place, so they don't have to come to one of us before they get to where they really need to go. So I think our discussion really hits a lot of points in that we're likely going to just view pediatrics very differently, that this doesn't have to be a lifelong condition necessarily, that this can be something that we screen, try to prevent from getting more intense, and then making sure that some of that is brief, and then being flexible with, okay, brief treatment didn't work very well, and having that decision point as to, okay, do we stay here on the course? Is it best for the family and this child, or are there other options out there that might better address, so that we can continue our prevention screening goals in integrated care? So I guess I'll kind of open it up from that perspective. If this sparks any thoughts in anyone, or any want to dive deeper into any one direction.
Acknowledge the challenge of preventative care and the need to diagnose and bill.
Yes.
Already with pediatrics, there is appropriately increased hesitancy about assigning a diagnosis in brief care, because you don't have all the information. There's so much important context. You don't want to over pathologize a child. And yet we know in order to bill for a visit, you have to have some sort of diagnosis. And most of us in integrated care are working in an environment where you're having to bill. That is just so hard. And I think one of the things that is particularly difficult for newer BHCs who've been in a purely mental health setting before, is getting to a place where they're comfortable with that. I think it is a problem. It is a problem that I would love to see change in a broader landscape. And I think it's worth noting that this is an example of where you can take advantage of the culture of physical medicine and of primary care, because you get into some of these charts and there's all kinds of diagnoses, right? I mean, for the most part, physicians don't think that as hard as we do about whether or not they're going to go ahead and put that depression diagnosis. So we've got an elevated PHQ-9, you get a depression diagnosis in the chart. So I think it's an opportunity for us to push our comfort zone a little bit and diagnose practically rather than get hung up on accuracy the way we would appropriately in a mental health setting, because there are so many mental health diagnoses that come and go from the chart in physical medicine. And I'm curious for feedback there too, you know, if others operate similarly or what kind of feedback folks have gotten about that challenge.
I think I'll often have conversations with families about like the purpose of what that diagnosis is, why it's in there, and what it means. And I'll explain kind of like what we just talked about. Like for kids, we're looking at these as like short-term things. If we get treatment in, we're hoping we can prevent this from being a long-term diagnosis. But to get you services, this has to be on your chart. So if you see that on there, that's where it comes from. And I kind of just go ahead and tell families that, like, if you're looking at your medical record or if your doctor mentions this, like, that's where it comes from. And so that's why it's there. And I find that that conversation helps families some, because they look at these mental health diagnoses sometimes differently than they would like some of the other physical things. Like there's just like, well, what does it mean that my kid has this? And so I think just kind of preemptively going over that, talking about why it's a necessary part and that it could change. It could go away. We could change to something different as we get to know each other, but that's what we're seeing right now and why it's in their record.
Kristen, I think you brought up both Kristens. Kristen Johnson in particular brought up something really important, is that we do think about this probably more than and do provide probably more explanations, because we often don't really you can put yourself into a primary care visit yourself, you know, and just kind of think about the words that are used and how much we talk. And Kristen Thompson, as you were talking about, you know, fitting in with the culture, I think that's one of the most important things. It's just like when you walk into that clinic, how can you make that patient experience similar, whether you're going in for physical or behavioral health, because that makes it better for the family, right? We may be doing two very different things. Oftentimes we don't need needles unless we're doing needle exposure, but we're not really doing two different things. Like for the family, they can come into the same exam rooms that they would come into to see somebody for physical health. They might still get height and weight in some situations. They might still, you know, they make the appointment in the same place. Walking in and making sure that even those parts of the visit then are very similar to what your primary care team are doing. Obviously with different information that we may be providing or gathering, we might find that it isn't as important to provide these explanations if they're not expecting them from the primary care side, and maybe even modifying our explanations based on what the team thinks. You know, well, hey, when I approach a situation with depression, for example, how should we explain that to the family, or how do you explain that to the family? And then coming to some sort of agreement too, that we're all going to practice in somewhat similar ways, because it could be that families don't ask as many questions because they don't think about it, because it's just never come up on the primary care side. So we do come from two very different worlds oftentimes in our trainings. Most of our training programs are still very traditional, with outpatient therapy and assessment, very separate, like enigma happening somewhere else off site, and trying to bring that enigma into primary care takes some time to really sit back and say what's best for the patient. And when we can look at it from what's best for the patient, not what's easiest for me, or not even what's easier for the primary care team, but what's best for the patient, and how can we modify what we do so that when they walk in, it doesn't feel like a totally different experience for them.
I think just back to,
I think one of the things we're touching on here. Oh, everybody might be frozen.
can you hear me?
Go ahead.
Okay. One of the things that I was just going to say was the frustrating thing for me as far as billing goes is that the providers can bill symptoms. They can bill small things and still get reimbursed, and that's not something that we necessarily can. Now, I have played around with some like symptom like codes that are listed in a Medicaid list for Missouri, and they've worked. I haven't had an issue with them. So like when a kid comes in and they have some kind of behavioral issue, there's been a few times that I've used an R code for restlessness and agitation, which is like, what does that mean? You know, that can mean a million different things, but I've been able to, I mean, I have sent it to our coders several times, and it's come back with reimbursement. So it's just, that's one of the things that's like frustrating, but one of the things that we have a lot of, we can have a lot of growth in is just how we diagnose as BHCs, and looking for some of those caveats or sneaky winners, right? That we can get by. So.
And how many of us really got trained in like sneaky secret winner diagnosing? It, like, you know, we get trained to diagnose what's accurate, not to know how to play within the system that we're in order to best represent what's going on, best advocate for your patient so they get their treatment needs met. Like, there are so many competing things. You have to diagnose accurately. And I certainly don't want to come across as saying that I'm advocating for not doing that. You just have to balance a lot of things. And so what is accurate, billable, and not over pathologizing, that's a tall order. And I think it's just something we don't get enough training in. It's a lot of on-the-job training, and to Micah's point, following up with rev cycle, like, is this working? Can I do this? Is this effective? The other thing that came to mind when we were talking there is patient portals, right? I mean, we are getting to a place where all healthcare is in patient portals and all notes are in patient portals, but there's a lot of outpatient therapy where that is not happening. And you are not writing notes that are going to be seen by your patients unless they request a whole medical record. So I think that's another area where those of us in the field are having to adapt to writing in a way that we know patients are going to see that, and writing so that that's okay. I think integrated care is at the forefront of that. In pediatrics, I think there's this unique ethical issue that I have really struggled with of when you have particularly a slightly older child and you're documenting maybe a visit that you did just with that child, but knowing that it's going to their portal that their parent is going to see. What does that do to the expectation between you and the older child that this is private? How do you document in a way that's accurate, but that also isn't violating that confidentiality you have with the patient? And I'm really curious how other people on the call here have handled that, or just what the thought process has been around that for other folks.
Yeah, I think for me, this is, as an administrator, I think this is one of those sticking points. And also when I was a provider, it was very apparent to me whenever I got called to court about how things need to be really conveyed. And so one of the things that we recommend pretty strongly in general in the field, I think, is to present things that gives enough detail to indicate to the insurance company and to the people who might be consuming that information in a way that helps them be able to, say, oh, this definitely met the criteria for a paid session, and this will help you with the treatment, but vague enough that it doesn't include certain things. And so for an adolescent, for example, if an adolescent hasn't disclosed that they maybe are identifying as bisexual maybe, or even homosexual, if they haven't disclosed that to their parents yet, and they talk to you about that particular issue, or maybe they're becoming sexually active with another individual and they haven't disclosed that to their parents, being able to say, like, discuss like relationship issues while also educating the patient on, how do we have conversations with our parents about those things? You know, and maybe like scaffolding them to that space. And while I'm unmuted, not to throw another wrench in this, but how do we document about parents in the room when parents will be reading those particular records too? Like, we don't want to call a parent difficult. I'm just saying, throwing that out there. I mean, hypothetically, of course.
Oh, and Caitlin in the chat here, she added, this was brought up in a meeting this morning for me, and one provider noted that her own children's pediatric office had her children sign consents, acknowledging that parents have access to their portal. I have so many feelings about that. It feels informative and appropriate on the one hand, and I can only imagine what that does to a teen's willingness to go in and say, hey, I'm sexually active and I want to talk about birth control. Now, the reality is, like, parents probably going to find out if that was part of the medical visit anyway, but I think it's another layer of deterrence for that teen. That's so complicated.
I think these are complicated, sorts of conversations, especially about, I think for the most part, we're discussing information that we're trying not to make as sensitive. We're trying to make it very similar to what the primary care experience is like without behavioral health involved. So there are times where physicians or primary care providers ask parents to leave the room so they can talk, ask children about their drug use or thoughts about hurting themselves, and various things, or sexually transmitted diseases, I know is one that comes up here a lot. And so those are private conversations that have, and I think one of the things that I come back to as well is having this conversation with your primary care team as the behavioral health provider, and say, how are you handling it? Here's how I would traditionally handle it. Here's how I've tried to handle it maybe a little bit differently here. How should we handle it? Because I think when it's a we, it makes it so much easier. And we think about it, we sometimes silo ourselves, I believe, to thinking, okay, I'm getting involved in the culture, I'm getting myself involved here, but I'm still different than everybody else here. And the more that we can even kind of challenge ourselves with, okay, we might be, but we're not that different. And maybe we just need to take another step of feeling comfortable saying, let's practice together with this, because I want you to have everything. I want to be able to see all your notes, and I want you to be able to see all of mine. And so that I could go on vacation and you can look up the note and see my plan for safety, or see the things that I've requested the family to do, and review those recommendations with them. So that's not just something they do with behavioral health, but I think in this situation too, I'm just thinking of an example that has come up where a child wanted to have a pregnancy test, and the teen was talked privately with the physician, and the physician said, I won't divulge this to your parents, but here's the deal. If I give you a pregnancy test here, I have to bill you for this. So giving them alternative ways of finding out about pregnancy through maybe Planned Parenthood, other things. Now I'm getting into like a pretty sticky topic here, and so I'm not necessarily suggesting that this is how it goes, but again, having this conversation with the pediatrician was really helpful for me, because they get into these same situations where there was absolutely no way they can keep it private, because somebody's going to receive a bill for testing and be able to see that sort of testing was on there. So how do we handle these situations? Do we talk with families about this? Do we talk to the kids about this? I'm trying to find, we have our limitations with confidentiality. And we do not have to divulge certain information, but when it's available to them, it's really hard not to put important information into a chart. So I guess I always come back to, is this a discussion you can have with your primary care team so that you're all on the same page with how to handle sensitive information?
I love you're bringing us back to the following the culture and being the we. I love, thinking about being the we and how do we discuss and decide about these things together, because you're right there, they are probably just less wrapped up in some of these concerns than we are just by nature. And so I appreciate that. I also, which brings me back to Michaela, your comment about how do you document about the parent in a note they might be reading about themselves. We had a great conversation about this. I think it was maybe Robin and Carolyn and I got kind of looped into a conversation about how do you document parents' mental status in a note if it's relevant. And I almost go back to thinking about what the primary care provider is doing, thinking about how to write for the portal. Sometimes we have a little bit of a cushion in our jargon. So instead of writing that they're difficult, maybe writing that they are, their activity level was elevated or that they were agitated, or writing in a way that feels really clinical. Sometimes I think that's a way to say things that don't feel so judgmental because it feels more clinical. And so, as much as I don't love overly jargony notes, I want to be clear. Sometimes that's a way to add a little cushion around the difficult things you're sometimes saying. What about the slippery slope? Micah, would you talk to us a little bit about what that is and what that looks like in peds?
Yeah, so what that is, what we meant by that when we talked about that and wrote that down, was just the tendency for pediatrics to turn into long-term therapy at times, or for people to send referrals to you that are for long-term therapy. Earlier, Holly, you had talked about the pivot from brief to long-term, sending people on to long-term therapy. I think one of the things that is difficult about this is just the difference in presenting problems a lot of times with pediatrics. It tends to be more mental health driven, behavioral, and not as much the physical health concerns, medical concerns with the behavioral health approach to it. And so I think that a lot of times here, at least here at Northside, I've had a lot of people sent to me with the expectation that, Micah is a counselor and he can do therapy, and there's a long wait list at such and such place. And so we want him to take care of this. When in actuality, I'm a behavioral health consultant, or behavioral health consultants, we do things differently. And so I think, the dance that we have, the difficulty is just in explaining our role, our identity well. For me, it's been two and a half years at this point at this clinic, being a BHC. And I was still having conversations. I was having conversations yesterday about, okay, this is how I want you to explain my services to a parent. And so it's something that is an ongoing, it's an ongoing thing, just really sticking to our identity, and explaining our role well, and explaining, hi, I'm a behavioral health consultant. This is what this means. Yes, I have my license in counseling, but this is what this means, going back to that over and over again. And really informing staff and the pediatricians as well on what I do. Chelsea just put in the chat those dreaded introductions as therapist or counselor. Yes, stay away from that. But yeah, it's something that's something here though I'm able to do, and I think one of the ways to avoid the slippery slope but also help out in those areas is doing bridge counseling. If there is a long wait list, really being flexible. We have to be flexible in so many other areas of this job. And this is another way where I think if we stay rigid with just like, I'm just a behavioral health consultant, that's the only thing I do, I don't help out, with that bridge service, then we really do a disservice to our patients and the staff here. So that's one of the ways I think that's been helpful, has been to be able to provide brief therapy while somebody is on a wait list, helping them out with coping, all that kind of stuff. But yeah, it can really quickly it can really quickly evolve from that to long-term therapy if you're not careful and how you're communicating that. But I'm also interested in hearing if there's others with ideas on that, if there's any others that, you know, have some ways that that's been difficult, or even some ways you found to work around that.
Micah, I just wanted to make a quick comment. I am now Amanda Williams. We're in the same office, obviously. I appreciate what you're saying in terms of the psychological flexibility and the use of our role. And I just wanted to reinforce that idea that, you know, if we look at the numbers of people who take an outpatient referral for specialty mental health and actually follow through with it on their own, you know, with their own insurance, finding their own specialty mental health provider, like having that long wait right now as we're all overburdened, the system's overburdened. The vast majority, the vast majority don't follow through. So just wanted to reinforce that idea of the bridging and, you know, assisting and supporting in the meantime, or, you know, kind of even sometimes case managing in terms of describing steps for how to move forward. So I appreciate that piece.
One of the things I think about with this, because I like, Mike, I feel like you talked about like this idea of like flexibility and like setting boundaries, which I think is like one of the biggest struggles in this setting for me, because like you want to explain your role and you want to set these boundaries and say, this is like what I can do. And then as soon as you do that, something's going to come up and you're going to be like, well, okay, here's where I need to be flexible. And so it feels like the moment you've like kind of got it under your belt, like that's when it's flexible. And so I like to think about like, what else can I do with my team? So like, are there things that I can talk about with my primary care docs, where can I give them like a grounding technique that when kids come in with anxiety, can they take a few minutes to do this? Can I have we have like an additional like case manager at my office. Like, are there things we can work on where it's not just my responsibility to care for the emotional health of these families and these kids, but like, how can we work as a team to have really simple strategies that other people can do? And then kind of making those decisions for when to be flexible and when not to be flexible. I had a colleague recently point out that she had attended something where people were pointing out that can sometimes lead to inequitable decision making, because we often are subject to our own biases. And so that's something that I'm interested in hearing people's thoughts on too, is like, when we have these kind of guidelines that we set out for ourselves and we think, okay, this is a situation for when I'm flexible, how do we make those calls? And is there like a set process, or is it kind of just we make the decision based on whatever information we have in the moment? And how do we make that the most equitable process?
I think that is such a good and complicated question. And you think about, I mean, everywhere in behavioral health, you're taking into account the context, but that becomes especially important. I mean, we're weighing decisions like access to care, transportation. We know they can get to this clinic. You know, pay source. We know their insurance is taken at this clinic. And so there's all these factors about where they can access care and where they can't. And so maybe if we know they're going to be less likely to access care somewhere else, are we more likely to keep them? And does that mean we're offering, if situations were equal, are we offering something to one and not the other? And is that okay? Maybe that's okay because there are these other factors, and that's part of that. I also think, you know, there are families that have so much environmental context that is challenging. Does that make this a client that's too hard to handle in brief? Because there's a lot of instability in the family structure or housing or transportation. You've got complex trauma, like there's a lot going on. And then do we say, well, this really isn't a good candidate for my services here because there's too much? And then do we maybe say no to something where really maybe I could take a brief approach to a specific slice of this pie, and I don't have to address this whole thing, but because it feels overwhelming, I'm more likely to refer out. So I'm so glad you brought that up, because I think there's so much of our own just judgment and bias and our own stuff going into making those decisions on the fly that we have to be aware of. I think the other, in that same vein, thinking about diversity in primary care, we know that especially youth of color are more likely to get either over pathologized or underdiagnosed. And what's our role to play in that? The overdiagnosis of behavioral problems for Black boys, especially the overdiagnosis of like ODD or ADHD. What's our role with minimizing that and really making sure those things are accurate? Or on the reverse, for example, girls, or there's a whole bunch of different examples of where we don't diagnose because it's just boys being boys, or they do have this chaotic home life, and so really we don't need to diagnose ADHD because it's just environmental, or maybe we're not giving depression diagnoses, we're giving behavioral diagnoses, but for that individual, it's actually the way depression's looking. And so I think there's a lot of education we can all provide to even our primary care providers about how they're making those decisions and really being aware of their own biases as well as our own. There are quite a few people on the call today. I would love to hear from others about really anything we've talked about, or questions about how you do handle different things related to peds that you've encountered that you'd love to hear from a group.
So do you all mind if I circle back to something for just a moment? They can't hear me, I bet. They can't hear me. Can you hear me?
Yes.
Do you mind if I circle back to something for a moment?
Not at all.
Okay, so when we were talking about having the parents, sign or the kiddos sign an acknowledgement that their parents have access to their records, or asking the parents to step out of the room. I did not hear this, so forgive me if it was said. I always like to set a context and an agreement between everyone that's in the room before I ask them to step out regarding what would I immediately report back to the parent, right? So usually those are things that end up being dangerous behaviors, and that's going to differ for family, but I find that if I set that context up first and say, we've all agreed that A, B, and C is confidential, the kiddo and I are going to speak openly, and then maybe we make the decision if they're pregnant, if they're actively using substances, that would be a time where I would go back to the parent and discuss it. And you all may have said that and I may have missed it, because you can probably see that we're in the same room, and so I'm muting myself so there's not reverb, and so if I missed it, I'm sorry. But I just, even with setting up the visit, I think anytime you put that frame in first, you can refer back to it in terms of, remember I said I would need to bring mom in, or we agreed I would disclose if you were A, B, or C.
I'm actually really glad that you brought that back up, Robin, because I do think this ethics and diversity in this space, and the way I'm thinking about it, I think do dovetail in thinking about not only our ethical obligation and thinking about the culture in which we work, but also thinking about the diversity of each family and each family system, and who people identify as their family, or who people identify as their points of contact and things like that. For the most part, we're talking about minors here who have identified guardians, But I also think, obviously, like you said, like if it's a harm, but I think even that can be a differential kind of word. It's a very, I don't know, it's nebulous. And so like one parent may say, I want to know if my kid is driving too fast in his car. Whereas another one may be like, listen, if it's not like killing self or others, I really, and I'm using very loose language there because that's the language we hear. I mean, every family culture is different, and to respect the diversity of that relationship and that culture, I think is really valuable. But certainly we have things that are required, and we want to get the buy-in and have informed consent, even if it's assent from the youth that are involved. And a 3-year-old's probably not going to be able to say anything, but I don't know that these issues are pertinent to a 3-year-old.
I think relatedly, another issue that's coming to mind is in traditional mental health care, we're really picky about who's in the room. In physical medicine, whoever brings the child is in the room. So it could be an aunt or a grandparent or someone who's not documented in anywhere in the medical record who this person is, but that's who's brought the child to the visit. And so that is the person we're providing information to and getting information from. And that's another place where we have to stretch our comfort zone a little bit because it's so different. And yet, how do you navigate some of those issues? And, really, a forever complicating factor of working with peds specifically is that you're working with a family system. You're working with whoever shows up in the room and who's not in the room, but it's a lot of pieces to manage. It's a lot of pieces to manage from your treatment plan. And it's also just a lot of pieces to manage in your 30-minute visit. So think about, the extra time that it does take to set those expectations, like Robin just talked about, with, here's what we're going to talk about. Here's what I'm going, like, that's a whole conversation, right? And then you kick the kid out so you can talk to just the parents, and you kick the parent out so you can talk to the kid. And then, don't get me started on the 7 other siblings in the room that you're trying to manage. It's just a lot. And so everything takes more time. And it's a lot of dynamics to manage. And yet our expectation for ourselves is really the same, that this is brief, pretty quick, especially with a consult, a pretty quick turnaround. So, I think that's something just for everybody who works with peds to give themselves some grace around, but also to really have to be strategic to make sure that those different things aren't interfering with your ability to get visits completed. How do you weigh, like, yes, I know this is really helpful if I have this whole big conversation, how do I make this fit the setting?
I've often thought about this in relation to other topics, and in some ways it almost feels like a frequently asked questions about what to expect might be really helpful at times for topics like this, especially when for a family that says, there might be things I don't want to talk about in front of my child, and that kind of makes the front desk say, all right, here's some FAQs, things that you should know in this situation. And again, it kind of gives you at least a framework, because sometimes, I don't know if others are feeling this way, you have to make like a game time decision based on whether the parent, the demeanor of the parent, the age of the child, the behaviors of the child, the level of safety that you have to take with that family. So many factors are there, but even feeling like there's a plan that you can kind of draw out beforehand and follow as a guide, and so families are prepared for how these sorts of things are handled before you have to explain them.
That's so validating to hear the game time decision, because that is how it feels so much. Kristen knows, because she gets phone calls often from me. Hey, did I make the right decision here? Because it's such a balance. It's such a real quick. You're moving quick. You don't have that same amount of time that you would in traditional therapy. And so you're having to decide on some pretty heavy situations and decide on it quickly. So I appreciate you saying that, Holly, because it's very validating.
We have a training program here, and so there's two of us, and that sometimes makes it easier, but sometimes gets in the way of training at the same time, because you don't want to, you can be really efficient if you split up and in some situations, but then the trainee doesn't get to see what I'm doing. I don't get to see what they're doing. And so sometimes the you have to balance too the efficiency with training, or the efficiency with, I'm not going to totally understand how to provide guidance if I'm not a part of both the parent and the child. So then I'll throw that element in there too, that you're trying to provide good training at the same time, and help the child and help the parent and get to everything. It's a really big balance, but we often, before we go into a session, okay, who's in charge of the parent, who's in charge of the child, and of course the whole plan goes, changes, and none of that happens because we didn't think of something that came up. But just going in there with a game time plan, and I'm usually looking at the age and the issue coming in. I don't even know the family yet, but I'm like, I don't think this 11-year-old's going to want to sit and talk about this in front of their parents. And if they don't, like, we have codes and stuff, and then we with it looking seamless, kind of move through the game time plan. But it is really hard, Micah, and I'm glad that others are experiencing that, because it almost makes me feel unorganized when I go into it, but it's strategic, trust me, right? It's not totally unorganized. It's like what's best for this child ultimately. Usually we don't want them to hear certain things, or they don't need to be a part of certain conversations. So
Holly, I was just gonna mention that I'm a little bit laggy. Like, you guys are all making great points, and then I'm sorry, I'm like a step behind, but a couple of things that have come up for me just listening to you all, like what you just said, Holly, in terms of, sometimes we're wanting to be cautious about who says what around whom, or how we code things. I don't know if others have had this experience where I'm like looking at the parent, like almost like, they're talking about the kiddo in front of the kiddo, like this, and I'm just like, that child can hear you, right? So sometimes, you have to get very creative. I find that I have to get creative in terms of how to encourage the open conversation. But if there's, we can't stick a 3-year-old in the hallway but a 3-year-old can still pick up on certain things that are being said and dynamics. And sometimes parents are so wanting to unburden themselves of the struggles that they've been having, that I wonder if they're not monitoring themselves around the child in like an age appropriate way, or even a way that discusses the child's behavioral issues without kind of putting the kiddo down. And then this is going to sound tangential, but I'm just kind of trying to track other things that were coming up for me, is the idea of who's bringing the kid to the clinic. I think having intake staff really be aware of, sometimes different people are bringing the kid. Is that a guardian that can consent for treatment? Right. I don't think we often have very much time to look into that. And so having a team in this case, like that real integration that we can trust and rely on our intake staff to know there's got to be consent by a official legal guardian, if that makes sense, because maybe somebody else is bringing the kiddo, and maybe you tell me that may be less relevant because we're doing it in primary care than in specialty care. I don't know if that's true or not.
I think that's such an interesting issue, Robin, because when I was working in a pediatric office, that was a situation that came up. I felt like I really couldn't. I kept seeing this client because they had consented for treatment at the pediatric clinic, and I was included in that. They didn't need to re-consent for me to see them, but it was the situation where the child was with a neighbor and the parent was missing, and they really wanted therapy, but Burrell couldn't see them because they didn't have an ability to get a consent from a parent, and the parent had not signed off anything for this neighbor to provide medical care, but the neighbor could keep bringing the child to the pediatric office because there was already consent for treatment. So I saw this child for a year because I was the only one, like they were already in. And I was able to do that. So I do think that's another example where it's like, oh, well, this is a flexibility time because this is really what they need and they can't get it anywhere else. I'm noting the time when I think many of us could just talk about these kind of things together. It's so validating to hear others' experiences and to hear about a lot of these shared experiences and ways others have handled it. Any burning questions or things that we have discussed that anybody wants to follow up on before we part? So Emily, our lovely MOPA support representative, has added some great information in the chat about our next roundtable, which the other side of this here is a topic on older adults and working with integrated care in older adults. And then she's also got some information about some other MOPA events available. I really appreciate everybody participating, giving your feedback, and just attending these roundtables in general. We hope to see you again next time.